Hello and welcome. My name is Felix Mahfoud. I'm working here at the Saarland University Hospital in Hamburg, Saar, Germany. A very warm welcome to this session entitled How Does Paradise Renal Denervation Fit into Hypertension Treatment Management? This is a sponsored session by Rico Medical, and we're going to focus on data regarding renal denervation. As you all know, science is progressing. Data are accumulating about the safety and the efficacy of catheter-based renal denervation. We have various systems available, and one which is under clinical investigation and will be commercially available soon is ultrasound-based renal denervation. Together with me in this session here are Joachim Weil from Lübeck in Germany, Tsioufis out of Athens in Greece, and Philipp Lurz from Leipzig. He will also serve as the chat master in this session. So please utilize the chat, ask all the questions that you have, and Philipp will try his best to address your questions and comments, concerns. Well, you have heard about the most recent data on renal denervation, very likely. So after the first and initial trials on renal denervation that were in part uncontrolled, but also one sham-controlled study, which was called Sympathetic HDN3, which failed its primary endpoint, primary efficacy endpoint. A completely new set of trials was designed and conducted, and these trials used a completely different methodology. They were all sham-controlled, but they focused on different patient cohorts that were included then in these studies. They utilized new renal denervation technologies and techniques. And with these studies now, 5 in total that have been published and presented, we have a pretty solid database on the safety and efficacy of renal denervation and various subgroups from patients with antihypertensive medication. You will hear about that in a second, but also in patients without concomitant antihypertensive medication. And these trials were so important because they finally proved that renal denervation indeed is able to lower blood pressure without any confounding, namely antihypertensive agents. So particularly the proof of concept that has been provided by these studies is so important. And with the Radiance Trio trial, and you will hear more about this study in the next minutes, we have then also supporting evidence in patients on a triple fixed combination. So indeed, what the guidelines recommend in hypertension management is to put patients, in case they're uncontrolled, on triple fixed combinations. This is the last escalation step before you then embark on spironolactone or other reserve antihypertensive agents. And here, renal denervation has been tested against sham. This was presented a couple of days ago at the American College of Cardiology by A.J. Kirtney, simultaneously published in The Lancet. And this is very important supportive data for the use of renal denervation in clinical practice. So this was a kind of introduction. The session's objectives are to understand the most recent data on renal denervation, to review the consensus statements and guidelines that are available and what has to come next. And lastly, to discuss all you need to know about patient screening and patient preference for renal denervation or invasive device-based treatment options for patients with hypertension. So without any further ado, I'd like to ask Philipp Lurz now from Leipzig to give his presentation, which is entitled State of Renal Denervation Today, the Paradise System and Recent Clinical Developments. Philipp.
Dear colleagues, it is my great pleasure to talk about the state of renal denervation today, the Paradise System and recent clinical developments. These are my disclosures. Arterial hypertension is the reason number 1 for morbidity and mortality, and as such represents a disease burden really around the globe. Although it would be desired, hypertension control rates have not relevantly improved in recent years, but are in a plateau phase, as you can see here. Now, one reason why hypertension control rates did not improve is the fact that drug adherence is still a major problem. And the limitations in drug adherence is not just because patients forget to take their drugs, but also because they don't want to take drugs. Here you can see the results of an app-based intervention to remind patients to take their antihypertensive drug medication. And you can see that this intervention did not improve blood pressure control in these patients, highlighting the fact, and we as physicians have to face it, it is often an active decision by patients not to take drugs. Now, renal innervation represents a non-pharmaceutical approach to improve blood pressure control. And the rationale for that therapy and also the proposed mechanisms are highlighted and summarized on that slide. Blood pressure control is governed, amongst others, by sympathetic nerves running between the central nervous system and the kidneys. And an increased activity of afferent nerves can cause vasoconstriction, whereas an increased activity of afferent nerves can lead to activation of the renin system, the RAS activation, sodium retention, and reduced renal blood flow, all of which cause arterial hypertension. And the idea of renal innervation is to reduce sympathetic overactivation. Now, the unfortunate negative results of the Symplicity HTN-3 trial led to a certain reprisal of future trials in the field, the next generation trials in the field of renal innervation. What was different here? Well, different was the approach and the design of these studies to avoid and reduce confounding by drug changes and also patient adherence. Some modifications and improvements in patient selection and this is of importance, procedural modifications and application of new technology to improve procedural efficacy and also reduce variability. For renal innervation to be effective and reproducible, it is important to have a sound understanding of the anatomy of renal sympathetic nerves. We now understand that these nerves, they are further away from the renal artery lumen at the proximal portion, and they run closer to the renal arteries at the distal proportion. This means for renal innervation to be effective, a certain penetration depth is necessary, and ablations should also be performed at the distal part of the renal arteries. Now, the Paradise endovascular ultrasound system is an ultrasound-based sonification or ablation system which is water-cooled to preserve the endothelium of the renal artery. It provides lesions with a penetration depth up to 6 millimeters to reach sympathetic nerves, even at the proximal portion, and this is important to be effective, it provides truly circumferential lesions to reach sympathetic nerves running at the superior, inferior, posterior, and anterior aspect of the renal artery. So in summary, the next generation trials in the field of renal innervations applied more advanced technology and a different approach to the procedure, providing more reproducibility and more effectiveness. Using 24-hour blood pressure recordings, both as an inclusion criteria but also as a primary endpoint, reduced the confounding of regression to the mean and provided less noise in outcome measures. Standardification in medications, particularly in the TRIO trial, and I will come back to that in a second, in which a 3-drug polypill was used, reduced variability from medications, and measurement of drug metabolites in urine allows to correct for medication confounding in these trials. Now, taking all of that together, we now have 3 next-generation renal innervation trials published, the Radiance HTN solo trial and the Spiral HTN off and on-med trial. All these 3 trials demonstrated superiority of renal innervation as compared to a sham procedure in patients with arterial hypertension. And you can see that in the sham group, there was very little change in blood pressure from baseline to follow-up, highlighting the clever and sound design of these trials. We now very recently have also the results of the Radiance HDN Trio trial, a trial with a very solid and robust design. What is important here, and this is completely new, is that all patients were on a fixed dose three drug combination pill to, as said before, avoid confounding by concomitant medication as much as possible. And also in that trial, in the intention to treat analysis, and even more so in the complete ABPM population, there was a significant superiority of renal innervation with a higher blood pressure reduction as compared to the sham group, highlighting here. So again, another positive trial in the field, highlighting that renal innervation works in patients with high blood pressure. And these effects, they are not just observed at 2 months, but actually further down the line. On the left, you can see the results 6 months and 12 months after treatment in the Radiance HDN solo trial. And what is important, this blood pressure medication is not just at one point during the day, but renal innervation works 24/7, as illustrated here. We do have some longer follow-up data, 1-year data from the ACHIEVE trial, with illustrating that the initial blood pressure reduction is well maintained during follow-up. And then out of our Leipzig experience, follow-up up to 2 years, again, good maintenance of the initial blood pressure reduction after treating those patients with the Paradise system. Now, this is a summary of the Rico Global Clinical Trial Program. I've demonstrated the latest developments and results of these prospectively designed trials, but there are also further studies planned in the field of renal innervation, concentrating on other patient groups such as isolated systolic hypertension, looking at additional indications as renal insufficiency, arrhythmia, and also heart failure. And then the global Paradise system registry, which will give us further insights into the potential of renal innervation in a real-world setting. So in conclusion, HDN3 led to a reappraisal of renal innervation field, including a better understanding of the target, new devices, and important clinical designs. Thus far, 4 sham-controlled trials incorporating these lessons in patients studied both in the presence and absence of medications have yielded results demonstrating efficacy and durability with a very good safety profile. More of these redesigned trials will be reported in the coming months. Thank you very much for your attention.
Thank you very much, Philipp, for summarizing the data that is available so far. I think you made very good points in also showing not only data from sham-controlled randomized trials, but also from real-world studies, as you nicely elucidated on the ACHIEVE study, where we have 1-year follow-up, probably also longer follow-up than 1 year to be published very soon from this real-world patient population, showing larger falls in blood pressure, indeed, that what has been observed in the sham-controlled trials. But we have a variety of data sets now, all indicating that indeed renal denervation lowers blood pressure. And as you nicely said, in combination with antihypertensive drugs, but also in patients who do not receive antihypertensive medications. So I think that is very important and reassuring to see all the data being published. Well, data from clinical trials and real-world experience is sometimes different from guideline recommendations and position statements. We have the 2018 guidelines of the European Society of Cardiology and the European Society of Hypertension for the management of arterial hypertension. Again, as said, they were published in 2018, so far before most of the trials have been published. The most recent trials have been published, so they appear to be slightly outdated. And it is my pleasure now to introduce the past president of the European Society of Hypertension, Konstantinos, who's working in Athens, and he will review the consensus statements and guidelines and also discuss what is needed next. Kostas.
Dear colleagues, dear friends, I am Tsioufis, Professor of Cardiology at Athens University in Greece, and I'm very happy to provide a short review of consensus statements and guidelines about renal denervation and to discuss what is needed next. This is my conflict of interest. And in 2018, when the European hypertension guidelines were released, there were conflicting data regarding the efficacy of renal denervation. In the meantime, recent studies of established technologies, including some of active comparators, have been published. All these second-generation renal denervation studies have proved that renal denervation is an effective and safe procedure to reduce high blood pressure in various clinical settings. Also, there are a remarkable number of studies ongoing or soon to be published, adding more data in this field. Here we appreciate 4 multi-center, blind, randomized, sum-controlled renal denervation trials established efficacy of renal denervation by using ultrasound energy, intravascular ultrasound energy to disrupt the renal fibers, or radiofrequency energy to disrupt the renal fibers. Let me present very briefly these fundamental studies. Starting from the Radiance HTN solo study in patients without antihypertensive medication, renal denervation by using ultrasound energy was associated with a statistically significant and clinically relevant blood pressure reduction by 8 millimeters of mercury, compared to a small reduction in daytime systolic blood pressure in the renal denervation arm. That means there was a clinically meaningful net difference between the renal denervation and the SAM ablation arm. Similar, the Radiance HTN trio study in patients on 3 antihypertensive medication, there was consistent reduction in daytime systolic blood pressure in renal denervation arm compared to the SAM ablation, giving a net difference of 5 millimeters of mercury. Similarly, we have consistent reduction in ambulatory systolic blood pressure in the Spiral project in patients without antihypertensive medication, as well as in patients on 1, 2, or 3 antihypertensive medication. That means that we have solid evidence that renal denervation is an effective minimally invasive procedure to achieve blood pressure reduction, statistically significant and clinically relevant in office blood pressure measurements, but also in ambulatory blood pressure measurements by using different technologies. In this nice graph, there is a timeline of these key renal denervation second generation published studies in relation to the publication of a number of consensus statements by different scientific societies across the world, starting with the position paper for the working group on interventional treatment of hypertension of European Society of Hypertension in a couple of weeks after the release of the hypertension guidelines 2018. And then we have different consensus statements by Asia, by Africa, and also from other parts of Europe. Here there are the key findings of these clinical practice guidelines and consensus statements. I am not going to go in details through this very busy slide, but I would like to highlight 2 points. First, all the reports confirmed the efficacy of renal denervation in reducing the high blood pressure to treat uncontrolled hypertensive patients in various clinical settings. And second point, all these consensus statements try to provide an answer on the hot topic. who is the optimal patient to undergo renal denervation, who is the ideal candidate to undergo this minimally invasive and innovative procedure to reduce high blood pressure and to contribute to the better control of uncontrolled hypertension. Starting from the report from the Italian Society of Hypertension, the Italian experts provide two groups as optimal groups of hypertensive patients to undergo renal denervation. First group, patients with uncontrolled hypertension. But also, the Italian experts recommend that some other characteristics should be taken into consideration. Among them, these characteristics are patients who are not adhere to hypertensive medication, or patients who are intolerant to medication, or patients at high cardiovascular risk or hypertension-mediated organ damage. And it is worth to mention here a statement provided by this consensus statement by Italian hypertension experts. Renal denervation is the only blood pressure lowering intervention with efficacy demonstrated in patients with fully adherent as well as in patients non-adherent or partially adherent to antihypertensive medications. Thus, it is qualifies to be a feasible treatment approach on the difficult to treat hypertensive patients who need who does not necessarily correspond exactly to the definition of resistant hypertensive patients. A second group as potential ideal candidates for renal denervation are patients with grade 1-2 uncontrolled hypertension, and in patients also in this group additional characteristics should be considered, like patients with who are not adherent to antihypertensive medication, or patients who are poor tolerant to antihypertensive medications. Moving now to the consensus provided by the Taiwan experts. They identified 5 subgroups of hypertensive patients as preferred groups as preferred candidates for renal denervation. First group, patients with resistant hypertension. No question about that. Second group, patients with hypertension-mediated organ damage at the level of the heart, at the level of the kidney, at the level of the brain. Patients non-adherent. This is something very important. Patients non-adherent should be in a group for being optimal candidates for renal denervation. And according to these experts, non-adherent should be assessed in every patient with uncontrolled hypertension. Patients intolerant, we have to ask our patients about side effects of due to the antihypertension medication, and particularly for erectile dysfunction. And the last group, the fifth group, patients with secondary cause of hypertension, confirm that hypertension remains uncontrolled for a period more than 3 months, and in these cases, the Taiwan experts recommend that patients with renal parenchymal disease may be ideal candidates. Moving now to the Asia Renal Denervation Consortium, they report that based on available evidence, renal denervation should not be considered a therapy of last resort, but renal denervation should be considered as an initial therapy option that may be applied alone or as a complementary therapy to antihypertension medication. And they also identify some groups as ideal candidates for renal denervation: patients with resistant hypertension, patients with mast control uncontrolled hypertension. Mast uncontrolled hypertension is another potentially group for renal denervation. Patients with uncontrolled hypertension and established atherosclerotic cardiovascular disease, or patients with intolerant or non-adherent to antihypertension medication. And the last but not least, patients with combined uncontrolled hypertension with a lower pulse pressure or increased 24 hours ambulatory heart rate. Don't forget that increased heart rate has been mentioned by the European hypertension guidelines as an independent predictor or associated with adverse outcome in hypertensive patients. Last but not least, the report from South Africa, also they recommend renal denervation for patients with resistant hypertension, patients with non-adherent to medication, and patients with increased cardiovascular risk, 10 years total cardiovascular risk more than 20%. Based on these available consensus and based on these recommendations, let me summarize that all these consensus confirm that recent renal denervation trials has proved that renal denervation is an effective procedure. Renal denervation produce at the average 5 to 7 millimeter of mercury reduction in ambulatory systolic blood pressure and about 10 millimeter of mercury reduction in office blood pressure reduction with a reasonable safety profile. And in the big question, who is the optimal patients for renal denervation? All the consensus agree that patients with uncontrolled hypertension who are resistant, uncontrolled hypertensive patients who are at higher risk of major adverse cardiovascular events, patients with established hypertension-mediated organ damage, patients not adherence, patients with drug intolerance represent ideal candidates for renal denervation. Last but not least, patients' preference should be considered in our discussion about the selection of renal denervation as an ideal treatment option. Based on these data, what we expect from the future. Based on these data, it would be nice if future guidelines could provide recommendations about the detailed steps for pre-procedural workup and suggest post-procedural follow-up. And also, as additional clinical data from large randomized controlled trials become available in 2021, reappraisal of guidelines about their recommendation for the use of renal denervation in the clinical practice is something that it is needed, is something that is expected. With that, I would like to thank you all for attending my lecture.
Thank you very much, Kostas. This was a great overview of the available consensus statement and guidelines. And as you correctly pointed out, of course, the 2018 guidelines were grading renal denervation or device-based hypertension treatment as a class 3, but they clearly stated that this class 3 is recommended as long as further evidence on its safety and efficacy becomes available. And we have seen the data that has become available in the meantime. Again, 5 sham-controlled studies are published now. All of them indicate that renal denervation can safely lower blood pressure. So I think, as you summarized on your last slide, a reappraisal of the guidelines is probably expected and needed sometime soon. You also pointed out that the different guidelines and consensus statements are referring to different patient populations, high-risk patients, but also patients that have a strong preference to be treated with device-based therapies, which is quite important. But also it is important to understand what referring physicians need to know about renal denervation and how they should screen patients and how they should incorporate patient preference into decision-making. And it is my pleasure now to introduce Joachim Weil to give his talk on what do referring physicians need to know, patient screening and patient preference. Joachim, the floor is yours.
Ladies and gentlemen, what do referring physicians need to know? Patient screening and patient preference in renal denervation. Here you see my potential conflict of interest. As you know, lifelong polypharmacy has failed as a strategy to improve hypertension control. What you see here is the age-adjusted trends in hypertension, and the incidence over the last 2 decades have been around 30%. However, if you look for the control rates, we have been some success. However, about 50% of our patients are not controlled. This clearly states the need of alternative treatment strategies, and maybe renal denervation is an alternative. However, you remember the hypertension 3 trial back in 2014, which had cast doubt on renal denervation as a whole. And also we had some other trials like these ones here, but there were small trials, and hypertension 3 trials was the very first sham control trial. However, things have changed in 21, and now we have 4 very good sham-controlled studies, randomized clinical studies, which now clearly show that renal denervation works. So how to regain trust in renal denervation therapy? I think there are 5 different points. So be transparent, be responsive, meaning address obstacles to overcome, use care, be sincere, and be trustworthy. So meaning dividing information with patients and referring physicians. As I told you, we have 4 studies. They are summarized on this slide here. There were 2 using ultrasound as an energy source for renal denervation. The upper 2s and hypertension off and on trial was using radiofrequency energy. Those were patients without any medication, these 2 trials, and patients with medication on the other 2 trials. To make a long story short, the delta in office blood pressure versus baseline was about 10 millimeters of mercury in all these trials. And if you look for the 24 hours ABPM, there was a difference between 5 and 10 millimeters of mercury. So to understand the existing patient flow, I made this slide. You can see the patient usually looks for the generalist or the family physician when he first been diagnosed on hypertension. And then if it's somewhat difficult to treat, they will be sent to a specialist. And then the specialist usually decides if he will travel on for RDN site. However, there are also an alternative way, and this is self-referring. And what kind of patients are self-referring? And this is nicely shown by a recent study by Roland Schmieder from Erlangen. And he could show in this survey that patients without any medication, but a new diagnosed hypertension, will prefer renal denervation, and this is in the dark columns down here, over lifelong polypharmacy. On the other hand, patients with more than 3 medication also prefer renal denervation instead of taking many pills. So there's a stepwise development of a renal denervation program, and in my eyes, these are 4 steps. So set up a renal denervation center plan, and it's very helpful if you have a certified center by the special societies of your country. Then you have to build a multidisciplinary team, including cardiologist, hypertension specialist, and nephrologist. And then in the 3rd step, identify the referring physicians in your area. And then you start with internal and external education and communication, which is very, very difficult to be successful on a long run. So what are the stages of a referrer's journey? And this is shown in this slide here. First, you have awareness. So people need to hear about the results of the recent trial, for instance. And then in the 2nd step, they should think about this alternative treatment, so the consideration. And then this usually is followed by initial referral. And if we're doing a good job, you will have regular referring. What are the key success factors for this transition from initial referring to regular referring? That's a careful selecting patients that meet all the criteria for renal denervation, maximizing the positive patient's experience during he's in the hospital, and then communicate closely with the referring physician. So what kind of patients are preferred candidates? And this is still not fully clear, but I think there are 4 groups. First one is a true resistant hypertension, but also the patients who are non-adherent or intolerant to antihypertensive medication, because we do not have other options, treatment options for these. And patients with a hypertension-mediated organ damage because they are at high cardiovascular risk, and we need to control these patients. In this respect, we have made up a checklist in our hospital. This is shown here. So you have some baseline characteristic of the patients. You look for the pharmacological treatment, and this is very important to always try to exclude secondary causes of hypertension because treatment is quite different in these patient. Then there are some other exclusion criteria which are summarized down here. And usually we have a pre and post RDN evaluation and follow-up, and this is shown on this time scale here. So you start with the patient select, and then you have different steps, and you end up with the renal denervation at some point, and then the next day patient is discharged, but you will follow this patient usually in your clinic, and it's always nice to have a registry, and either a global registry or a local registry, which we had in the past. So let me summarize my talk. So there's a stepwise development of a renal denervation program, as I showed to you. Very importantly is the appropriate patient selection, where you establish the diagnosis, for example, of true resistant hypertension or patients with high cardiovascular risk. And second, consider which patients are eligible for the procedure. In building up a referral network, it's important to have personal communication with your referring physician, and that you have a good quality of medical treatment. And hereby, it's important to understand the appropriate steps for pre and post RDN procedure, as I showed you on the time scale. Emphasize the importance of follow-up care, including ongoing communication between the patient and the physician who sent the patient. And thereby, I'd like to thank you for your attention.
Thank you very much, Joachim, also for providing your tips and tricks in patient screening and patient identification for renal denervation. I received one question from the chat master, actually on the importance of sham-controlled trials and whether or not we do need sham control, so invasive placebo, in the near future. And this is a very good question. And I'm referring now to the European consensus statement on device-based hypertension trials, where we exactly addressed that question in stating that once the devices have proven in larger pivotal studies that they are safe and effective, it will become challenging ethically to continue with invasive placebo-controlled trials. So I guess sooner or later we'll have to say bye-bye to sham control, at least for the devices that have proven their safety and efficacy, as, for instance, the Radiance device did. So, colleagues, ladies and gentlemen, it's my pleasure now to summarize what we have learned today. I think very clearly uncontrolled hypertension remains a huge burden socioeconomically and medically. Non-adherence is a big problem in hypertension treatment. Up to 50% of all patients do not adhere to the prescribed antihypertensive medication. In the pathophysiology of uncontrolled hypertension, increased sympathetic activity, particularly from the kidneys, is an important source, and renal denervation may provide an alternative treatment option to patients with uncontrolled hypertension. Ultrasound renal denervation and radiofrequency renal denervation has proven its efficacy very clearly and very solid in randomized sham-controlled trials that were powered to show a difference in ambulatory and in-office blood pressure. The trials met their safety and efficacy endpoints, so I think it's very valid to state now that renal denervation indeed lowers blood pressure. We've heard about the importance of patient selection. Potential candidates for renal denervation are patients with uncontrolled hypertension, with severe uncontrolled hypertension, hypertension-mediated organ damage, patients at high cardiovascular risk, including those with post-stroke, atrial fibrillation, or hypertension-mediated organ damage, such as left ventricular hypertrophy. We also discussed the importance of patient preference and patients' non-adherence to antihypertensive medications, and these may also be potential candidates. Future guidelines and consensus statements will be released soon. I'm sure they will have to incorporate the most recent evidence and weigh their value in decision making. I think that renal denervation will be established, that's my personal opinion, will be established among other antihypertensive treatment options, including a lifestyle modification, medication, antihypertensive drugs, and devices. And here, renal denervation may represent the third pillar of an effective hypertension management to finally get patients to control and reduce their risk of future events. With that, I'd like to thank the speakers, Philipp Lurz, Konstantinos, Joachim, Weil, and I'd like to thank you for listening, and I'm wishing you now a successful and enjoyable EuroPCR 2021. Thanks for listening.